Good morning. I'm Leslie Cooper from the Mayo Clinic in Florida, and I want to thank you for this opportunity to join you at the first Mayo-Hadassah Medical Center Cardiomyopathy and Heart Failure meeting. I'm sorry I cannot be with you in person, but this morning we're going to address in the next 20 minutes the current management of cardiac sarcoidosis. With that, I'll share my screen. And relevant to this talk, I do not have any specific disclosures. My consulting relationships are in other areas. We're going to cover in the next 20 minutes the epidemiology and clinical presentations of sarcoidosis, the roles for advanced imaging, including PET scanning, cardiac MRI, and heart biopsy, and finally, current recommendations for management, including arrhythmias and immunosuppressive therapy. Let's start with a recent case that I helped participate in. This man was 53 years old when he presented last April with initially fatigue of recent onset and shortness of breath that was new for him at about 100 feet with orthopnea. His EKG showed atrial flutter, and he was placed on Xarelto, cardioverted, and his echocardiogram demonstrated a markedly reduced ejection fraction of 15% with elevated right-sided pressures. He had normal coronary arteries on angiography, but an elevated left ventricular end diastolic pressure. He was dismissed, but then returned to the Mayo Clinic on the 18th of April with recurrent heart failure symptoms. He had an extensive evaluation, which included this cardiac MRI that demonstrated severe global hypokinesis with relative akinesis of the base of the interventricular septum. He also had this delayed enhancement image, which showed arcs of white scar or inflammatory tissue in the epicardium of the anterolateral wall, as well as the interventricular septum and inferior walls in a nearly transmural pattern. This raised the possibility of a specific form of cardiomyopathy, and he underwent heart biopsy, which demonstrated non-caseating granulomas, illustrated here in the absence of significant eosinophils or necrosis. There was also extensive fibrosis. With special stains negative, this confirmed the diagnosis of cardiac sarcoid. The rest of this talk is going to focus on the roles for imaging, biopsy, and how to manage patients such as these. First, what is the scope of this problem? In Sweden, the overall incidence of sarcoidosis is 11.5 per 100,000. And here you can see that the age differences in men in the dark black line and in women in the gray line, with the peak age in men at about age 40 and the peak age in women at about age 55 following menopause. The curve is relatively flat out to about age 70 when there's a significant drop-off. In the United States, in Caucasian women, the incidence is similar to Sweden at about 11 per 100,000, similarly in Olmsted County. However, in the US, in African-American women, the incidence is much higher at 46 per 100,000, and that's all sarcoidosis. Cardiac sarcoid, which clinically is about 5% of all sarcoid, is also higher proportionately in African-American women than in Caucasians. In the Mayo Clinic experience, most cardiac sarcoid is associated with extracardiac disease. In this figure we published a couple of years ago, about 90% or more of sarcoid is associated with either mediastinal adenopathy or pulmonary disease. There is a significant role for splenic sarcoid, hepatic sarcoid, but lesser percentages in the brain and the eyes. And so when sarcoid presents, it is often with AV block because of the predilection for the base of the septum, as we saw in the case image with akinesis of the interventricular septum. About 45% of patients present with AV block as their main presenting manifestation. However, significant numbers present with heart failure and arrhythmias, including sudden cardiac death. This study is from Finland. And what's important is that although patients present more commonly with heart block, they tend to die of sudden cardiac death. 80% of the deaths in their series were related to arrhythmic death, not to heart failure or post-transplant or non-cardiac causes, as illustrated here in the pie graph. And so it's important to focus on risk stratification and the minimization of risk of arrhythmic death. What is the definition of sarcoid? Because heart biopsy is not widely available and often insensitive, particularly if not guided by electrogram images, we rely on clinical presentation and imaging for most diagnoses. The first category of diagnosis is definite sarcoid, which includes those patients who have heart biopsy evidence of granulomatous disease in the absence of alternate causes. And then a clinical syndrome, which would include high-grade heart block, inducible or spontaneous arrhythmias, or a steroid-responsive or unexplained cardiomyopathy. If there is no heart biopsy, then biopsy of an alternate tissue, such as lung or lymph node, is recommended, and cardiac PET or MRI can confirm the diagnosis in the heart. We're going to focus on those criteria next. I would emphasize that there are a number of disorders that can mimic cardiac sarcoidosis and are actually more common. Lymphocytic myocarditis, arrhythmogenic cardiomyopathies with a genetic basis in particular, and some systemic granulomatous diseases such as granulomatous with polyangiitis and eosinophilia. Now, in those patients who have confirmed sarcoid in the lung or elsewhere, a cardiac evaluation is recommended, but it's limited to an EKG, echo, and a good cardiac history with family history as well. If there's no significant abnormality on the echo or EKG, no further advanced imaging is recommended in this 2014 Heart Rhythm Society consensus document. However, if there are abnormalities, cardiac MRI and/or PET imaging is indicated. I'd emphasize in my practice that I typically use cardiac MRI if there are no contraindications because of the excellent negative predictive value. This is an image of an echocardiogram of one of my patients from Rochester, Minnesota, who had a basal septal aneurysm. She had biopsy-proven cardiac sarcoid, and I would emphasize that this finding, although it's rather specific for sarcoid, is only present in 13% of patients in our series. Most echocardiographic findings are not specific. And that leads us to MRI. This is another MRI image of a patient of mine who had fairly diffuse pattern of delayed enhancement in a non-ischemic distribution. The anteroseptal delayed enhancement is epicardial and mid-myocardial. The infraposterior enhancement is mid-myocardial, with sparing of the endocardium, consistent with a non-ischemic mechanism. So what is the value of delayed enhancement for diagnosis and prognosis? In two meta-analyses, the first illustrated here, if delayed enhancement is present in sarcoid, the mortality rate is 3 times higher than if it is absent, at a rate of about 3% per year. In the second meta-analysis, if delayed enhancement is present, the risk of death or transplant or ventricular arrhythmias is also much higher. So they're both prognostic as well as diagnostic utility to the pattern of delayed enhancement. PET imaging is similar. In PET imaging, we recommend both perfusion, in this case with ammonia, combined with fluorodeoxyglucose for metabolism. It's the match pattern of a decrease in perfusion illustrated here on the left with an increase in enhancement here on the right that is most specific for cardiac sarcoid in the right clinical context. The absence of perfusion abnormalities raises the possibility of a false positive, such as inadequate diet prep. The presence of a matched defect with decrease in perfusion and increase in metabolism carries a 4-fold increase in the risk of ventricular arrhythmias or cardiac death over the subsequent 3 years, as initially reported by Ron Blankstein at the Brigham and Women's Hospital, and more recently by many other groups. This is the figure from Ron's paper, first published in 2014, that demonstrated that the presence of a matched defect in the red Kaplan-Meier curve over 2.5 years was associated with about a 40% risk of ventricular arrhythmias or cardiac death, much higher than if those were absent. For both cardiac MRI and for PET scanning, the presence of right ventricular involvement independently carries increased risk of cardiovascular events. A few months ago, this paper was reported from Japan demonstrating the distribution on cardiac MRI on the left of delayed enhancement patterns and PET scanning with increased FDG in the middle and gallium on the right in a typical 17-segment MRI image. And you can see that the most common areas affected on cardiac MRI and PET scan were the base of the septum and anterior wall here, inferior anteroseptum, infraseptum at the base, consistent with what we know from autopsy studies that sarcoid preferentially affects that region of the heart. PET scanning and FDG imaging are complementary, particularly if you have a more diffuse pattern of FDG uptake. A truly negative PET scan can help decide that that is a false negative. And similarly, this paper this past year in JACC Cardiac Imaging went into more detail regarding the complementary roles for PET and MRI in the evaluation of both active and more chronically inactive cardiac sarcoid. Well, what is the prognosis overall? This report, which came from the Mayo Clinic experience, first 400 or so patients, was the first to report the outcomes in both definite sarcoid with heart biopsy positive granulomas, probable sarcoid with extracardiac granulomas on biopsy and positive cardiac imaging, or the new category of presumed sarcoidosis with no biopsy in the heart or elsewhere, but positive imaging findings in the heart with PET or MRI. And the risk of hospitalization, death, or significant ventricular arrhythmias for cardiac cause was 5% per year over the first 10 years in all three groups. What then is the role for biopsy? Since we have such great imaging, do you ever need to do a heart biopsy? And the answer is yes, sometimes. However, the focal nature of the disease limits the utility of sarcoid and almost mandates the use of some sort of image guidance. This figure from Rina Kandelen's PhD thesis in Helsinki demonstrates at autopsy all the reports of locations of cardiac sarcoid, and I would point out that the RV free wall and the LV free wall are frequently involved. Those are areas that have increased risk of endomyocardial biopsy. Furthermore, the base of the septum can get very close to the outflow tract, and bioptomes crossing the tricuspid valve cannot often make 90-degree or greater turns without risking perforation, and therefore biopsy is, in many cases, high risk or infeasible. At Mayo Clinic, we have typically used electrogram guidance in those cases where there is no extracardiac tissue to biopsy. In the absence of a decreased voltage less than 5 millivolts with a fractionated signal, there is very little value to biopsy. In a purely normal left ventricle where there are no accessible regions or right ventricle, we would not recommend proceeding with biopsy in the setting of normal electrograms. In the areas that have fractionated signals with decreased voltage, the yield can be up to 70%. So what about management? We're going to focus now, the last half of this talk, on the role for ICD and the role for immunosuppressive therapy. In this large paper from the New England Journal 2 years ago, which looked overall at cardiac sarcoidosis, the risk, there was one table in the supplementary online appendix on the management of cardiac sarcoid, and they did recommend the use of systemic immune suppression in clinically meaningful cardiac sarcoidosis, in addition to appropriate arrhythmia management and guideline-directed medical therapy. The 2017 AHA-CC guidelines for the management of arrhythmias include specific recommendations on cardiac sarcoidosis. Specifically, for secondary prevention, there's a class 1 indication for ICD. For those with an ejection fraction of less than 35%, who for primary prevention, there's a class 1 indication. And for those patients with suspected or confirmed cardiac sarcoid who have had syncope or extensive scar on cardiac MRI or PET scan, and who are a candidate for a pacemaker, implantation of an ICD at the same time has a class 2A recommendation. Furthermore, the European Respiratory Society has made specific recommendations regarding the management of cardiac sarcoid. Here you can see in those patients who have clinically relevant cardiac sarcoid, for example, with heart block, pacemaker would be indicated with ICD. This is very similar to the US recommendations from the ACC and AHA. For medical management, the use of glucocorticoids such as prednisone or methylprednisolone with or without a steroid-sparing agent is considered the first level of therapy. If this fails, going on to higher dose steroid-sparing agents and or infliximab or adalimumab, which are TNF-alpha inhibitors, are the next step in therapy. This is an example of a patient from Finland. This image was shared by my colleague, Jukka Letoen, demonstrating following infliximab the resolution of numerous inflammatory granulomatous lesions in the lymph nodes as well as the heart. It's a case which shows the possible value of TNF-alpha inhibitors for the management of cardiac sarcoid. There are now 5 reports, including this one from the Wellstar Medical Center and Johns Hopkins, demonstrating essentially the same findings, that TNF-alpha inhibitors decrease the mean and the max SUV in patients with active cardiac sarcoid, but ejection fractions don't tend to change. This is the data from the Mayo Clinic, which was published 2 years ago, demonstrating that 88% of patients treated with methotrexate and prednisone and 84% of patients treated with Humira-containing regimens had a significant decrease in FDG. It's worth noting that although you don't get complete PET suppression, none of the 7 of the 19 patients who had incomplete suppression in our study had clinical events out to 4.2 years of follow-up. Small numbers to be sure, but it raises the question of what is the correct threshold to define success in suppression of FDG. That's a question that we do not have an accurate answer to currently. And finally, 8 of 9 patients whose discontinued immunosuppression had relapsed radiologically. It's unclear what the clinical significance of those imaging features are. Finally, I would be remiss to not mention heart transplant at such a heart failure meeting. There is a risk of recurrence histologically in the allograft. It's about 5% in this large multi-center study, but it does not affect the risk of graft loss or death following transplant. So probably worth monitoring for, but not a reason to deny heart transplant. With that, I'm going to finish my talk, and I would also note that in my slides, I have numerous supplementary slides, and I'm provide my email. I'd be glad to answer any questions asynchronously offline.